All right, and we're back after the briefest of breaks with Rayan to introduce our next speaker, Dr. Gifty Asare. Rayan, take it away.
So thank you so much for coming, Gifty Asare. We are so pleased that you're able to join us. Our next session is going to be talking around cross-sectoral solutions, supporting survivors of gender-based violence, related trauma, brain injury through survivor-led program. Just a little bit about Gifty Asare. She's a Ghanaian Canadian researcher from Montreal and is currently the Director of Research and Community Impact at Women at the Centre, which is a nonprofit by and for survivors of gender-based violence. So without further ado, I'm going to ask you to share your screen and share your wealth of information. I know the work that you've been doing in research on this issue. So thank you so much. And again, just a reminder, if anybody has questions, to post those in the Q&A box, and we will be posting also any links in the chat box as we go. So thank you.
All right. Thank you so much, Rhian, and thank you everyone for being here today. I guess the introductions have been done, so I can jump right in. So today I'll be talking about Cross-Sectoral Solutions. This was a 3-year funded project by the Public Health Agency of Canada. And as Rhian shared, it's to look at how we can support survivors of gender-based violence with a traumatic brain injury, and doing that with survivors at the center. So before we begin, I'm just going to share a land love, land reflection, land acknowledgement, solidarity statement. At Women at the Center, we shared how this is a survivor-led organization that is pan-Canadian. And although we are pan-Canadian, we do operate largely remotely. However, a lot of us are based in Ontario. As what we know as Ontario, I personally am in Montreal, Georgiake. And so Women at the Centre acknowledges that the land on which we operate on is territory of the Huron-Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, Métis, Inuit, and the Mississaugas of the Credit, and that these lands were taken without consent. And so today this land is still home to many First Nations and Indigenous people from across Turtle Island. We also want to acknowledge that that there are those who are here involuntarily as part of the transatlantic slave trade. And so an inherent part of our work is taking action to disrupt, to dismantle the embedded impacts of colonialism, racial capitalism, imperialism, and patriarchy. And so today and always we stand in solidarity with Indigenous women, girls, trans, gender diverse, and two-spirit people. And we recognize that the work we do must be rooted in respect for the original caretakers of this land. So today, this is a very simplistic agenda, and we have a little bit of time, but essentially want to talk about the intersection of gender-based violence and brain injury, and then a 20-week pilot program that is Cross-Sectoral Solutions, and then the key findings and recommendations from this project. And I know that this is an event looking at elder abuse and the prevention of elder abuse and dementia. And taking a different approach here with regards to this project. Its primary focus or aim wasn't specific to the elder community or the older adult community. However, it does tell us a lot about how to have an effective program for survivors living at this intersection. And it also tells us a lot about kind of the key activities and supports and services that will really support a survivor and an individual across the lifespan to ensure healthy aging. And so that's a little bit of the approach that I'll be taking today. And so, without further ado, I know that folks here probably most likely know about intimate partner violence and traumatic brain injury. But I want to highlight the complex nature that includes cognitive, physical, psychological, emotional, even financial challenges that are then further complicated by socially derived barriers to care and well being, and how traumatic brain injury also does the same. And so looking at the intersection of the two once they kind of come together. And so, why does the intersection of intimate partner violence and traumatic brain injury matter? Well, prior to COVID-19, intimate partner violence was alarmingly common in Canada, impacting 1 in 3 women throughout their lives. And as the governments advised people to stay at home, reports of IPV in Canada surged by 20%. And the severity of the violence escalated, leading to what we now know is a parallel pandemic. And so, Women at the Center specifically didn't only see an increase in the number of cases of gender-based violence, but also in escalation of the frequency and the severity of the violence. So, for example, compared to pre-pandemic numbers, crisis calls increased by over 300%. And then the number of risk assessments and safety plans conducted with gender-based violence survivors increased by over 900%. And 51% of these cases were assessed or identified as high risk. And so that's with that, we had almost 50% of the survivors were disclosing that they had been strangled by their aggressors in the last year. And strangulation has been identified as one of the biggest factors for physical harm and death, because the abuser literally holds the victim's lives between their hands. And so that calls us into action, quite frankly. And note point 3 here, that brain injury among survivors of IPV is a critical issue because 75 to 92% of women likely experience a brain injury from the facial, head, and neck injuries that they sustain. Also wanted to take some time to advocate and to look at the language that is being used throughout the presentation and this event. So Women at the Center advocates that language is a powerful tool. It not only shapes the experience of violence, but also the profound impact of how people in communities are represented and thereby treated. So we advocate for the use of gender-based violence in place of intimate partner violence to encompass the various forms of violence that may not align with the restrictive ways in which IPV is currently conceptualized, not only within policy, but within practice as well. And you'll note that there is still language of IPV being used because in the literature, in research, in the statistics being referenced, those were the terms that were exactly referenced. And so to ensure that our citations are accurate, that language persists there. However, making the shift is important because we know that there are survivors of sexual violence and of human trafficking, which are all individuals that we serve within our organization. And they've shared that oftentimes they don't identify as being in an intimate or a romantic relationship with their aggressors. And so consequently, this impacts their access to much needed services and supports. The other kind of view or perspective that's worth noting as well is that language can sometimes present barriers to access. And so thinking about older adults, we have another project called Truth and Transformation that's looking at the experiences of Black people, Black women, girls, gender diverse, and trans folks across Canada, and looking at the racial inequities that are present. And in that study particularly, we noted that the language of intimate partner violence and gender-based violence didn't necessarily resonate with our older adults. Even the language of domestic violence was somewhat of a barrier. And so using language that was colloquially acceptable and culturally acceptable was very important. And so always kind of inviting folks to think about their use of language and how it can be accessible depending on the people, the communities that they are serving. And so we look at the impacts of gender-based violence and brain injury, and we note that there are all of these experiences across the different facets of humanity, really: mental, physical, emotional, social, and financial. And here I've just listed a few, but thinking about gender-based violence, we can see how a survivor might be hit, kicked, or shook, and how they might experience low motivation, fatigue, poor appetite and sleep, fear, anxiety, isolation, and how the social ramifications of that may be poor financial stability and independence, as well as some difficulties with childcare. We can then see how, for brain injury, the specific symptomology might look like difficulty expressing emotion, slow information processing, memory processing issues, problems with concentration and attention, coordination, as well as chronic pain. So we can see how we might have some unique and nuanced symptoms and experiences with regards to each of these events, but we can also see how they will intersect and have some social ramifications. And so, for example, this could lead to isolation, help-seeking behaviors, a loss of identity and self-esteem, and this could all be compounded and exacerbated if you have elevated rates of unemployment, poverty, homelessness, and thereby resulting in these substantial economic repercussions, such as a loss of income and productivity, and then, of course, the higher social and health-related support costs across the individual's network, and then across the nation. And so the impact of gender-based violence and brain injury is not only at the individual level, but we're really thinking about all the different networks with which there's an impact. And we're thinking about the individual, their support, their caregivers, their family, as well as their caregivers, peer navigators, service providers, and then beyond to kind of think more about the municipality, local costs, as well as governmental costs. And so, given the specific topic that we have today, or the specific emphasis on elders, I wanted to kind of highlight two areas that are critically impacted if you are a survivor living at the intersection of gender-based violence and brain injury, and thinking about how that could be compounded and the effects of that throughout the lifespan and then in aging. And so memory being one of them, a survivor may exhibit difficulty learning new ideas, forgetting information, losing or misplacing items, and then trouble scheduling. And some support strategies that have been found to be effective would be to provide summaries and recaps, to verify understanding as one is interacting with the individual, having memory aids. And so popular, at least among some of our survivors, are stickies, whether like the physical, like sticky notes, or even those on the desktop or computer, having checklists, reminders in the form of notification, emails, phone calls, and just increased interactions overall, and then specified locations for interaction so that there's an anchor that serves as a reminder for individuals as well. Another area is mood and emotion. And so survivors living at the intersection may exhibit abrupt mood changes, emotions not aligning with the situation, escalation of anger or irritability with small triggers, with difficulty de-escalating, symptoms of anxiety and or depression. And some of the support strategies would include monitoring the symptoms. And so maybe having a symptom diary or journaling, avoiding responding emotionally if you are the caregiver or a support person, recognizing triggers and offering alternative approaches, and then creating, implementing techniques of regulation, particularly mood and emotional regulation. Now, worth mentioning again that these are symptomologies and occurrences that we've observed with survivors living at this intersection, but you also might recognize that these are also experiences that you could see in older adults that have dementia or cognitive decline. And so noting that we can imagine how living at this intersection and then aging and having the compounded effects of dementia or cognitive decline could make this much more difficult to cope with. And so bringing that awareness about earlier on could support in being protective against what might be a worsening of these situations. It's also important to know that these support strategies are not only for the individual that are experiencing these symptoms, but really for the care network that's supporting an individual as well. So, for example, monitoring symptoms might seem straightforward, but of course, if you're the one experiencing it, it might not be as obvious. Journaling is almost counterintuitive to having to note take, which can be extremely taxing. And so thinking about supports and the individuals or the people that are going to support is also very much critical when trying to help individuals living at the intersection. And so I'll shift to talk about the project Cross-Sectoral Solutions and why it was named such. And so we really wanted to emphasize and center a holistic wraparound approach to this program. And I know that that's also words that were used just recently by Megan when in the presentation ahead of mine, but it is important and it is crucial. And we've also found it to be extremely effective. And so this particular program or pilot project had 21 interdisciplinary students. So these were students that were part of the services that we offered. And so we had occupational therapy students, we had speech language pathology students, we had some nursing students as well. So essentially across 10 programs and in 7 schools. And we had meetings with different individuals that had expertise in the areas of concern. And so we had a Stakeholder Advisory Committee, so that's the SAC. And so across the 3 years, we had 12 of those meetings. We also had WeSec, which is the Women at the Center Survivor Expert Collective. And so these are survivors that are living at the intersection of gender-based violence and brain injury. And they were instrumental throughout the program, not only in the initiation, but the development, the planning, and the accountability of the project. And then we had host site meetings. So we had 3 host sites across Canada. And these were organizations that were serving survivors that were living at the intersection in one way or another. And they also enabled us to ensure that we had representation, for example, having French and English, Francophone and Anglophone representation across the nation, and also other marginalized communities, including those who have disabilities, Indigenous, Black folks, so forth and so on. And so with all of these individuals a part of the project, we were able to have 46 unique partnerships to really ensure this cross-sectoral approach. And we had one pilot program that was launched last May to September. 25 survivors participated, and they were supported by 5 peer navigators. And so all in all, this project came to an end last month. Can't believe that was just yesterday. But essentially, we had 14 new knowledge mobilization events come out of it. One conference that we held in March, a 3-day conference held in March, as well as 17 new knowledge mobilization products. And that's a lot for me to just share and kind of regurgitate, but all of it can be found on the Women at the Center website. And we kind of link all of our resources and events there as well.